So this is diagnostic sheath, and this is obturator. So we use this obturator. We use this obturator to keep the sheath. If you don't use the obturator, then what happens? If the sheath hits something, it bends. Okay, so obturator prevents injury to the sheath. Huh? For all sheath you get obturator. Understood? So whenever you are storing a sheath, storage, like you are after use, you are going to store the sheath. So you put the obturator and then keep it, so that the tip doesn't bend. This has happened with us before. So once we buy it, we keep this obturator aside, and then after using this, we are just keeping it like that. So two instruments hit each other, and then this tip gets bent. Just see that tip. So do you understand that? Is there any doubt? No? So it is diagnostic sheath. But give it to me. I'll show you how to assemble it. See, any sheath will have no valve is there, but can you see these lines? So first you see what you are doing. You are trying to align it like this. No. You first align these two lines. These two lines to each other, and then there is one groove here. Can you see that groove? You align all these things together. Now it is okay. So there is always a technique to do it. Don't do it forcefully. This is inflow channel. So the normal saline which we use as distension media, we are going to attach it here and then do the diagnostic scope. The scope will go from here. So when you use this, instead of obturator, you will take out the obturator and you will insert the scope inside. Correct? So now again, when you insert the scope, you have to align these two lines, and there is one groove here. Can you see that? Yes. You align all three together and then align. Okay. So now automatically the normal saline and the light cable are opposite to each other. You got this? Normal saline we will attach here, light source here, and then start doing the hysteroscopy. So this was about diagnostic sheath. Then we have operative sheath. So I hope there is no doubt about diagnostic sheath now. Now this is operative sheath. So operative sheath has two sheaths. One is inner sheath, one is outer sheath. So now inner sheath has three channels. One is for scope, other one is for operative instruments, and third one for fluid, not water, fluid. So either normal saline or glycine we don't use in this. We use normal saline. Glycine we use for resectoscope, right? And this is outer sheath. So outer sheath has only outflow, and there are holes here to collect the fluid inside the uterine cavity. Can you see the holes? Yeah. See this. Then 2.9 है ना, बंद करो दियो. I'll show you assembling. Don't run ahead of me. I'll show you everything. Otherwise, there is no need of me, right? So when you want to assemble, see what happens. If you do yourself, you will do it wrong. If you listen to me, I will tell you the techniques of assembling also. You got my point? So now, outer, inner, inflow, outflow. So they are never in one line. They are never like this. So they are in opposite direction. So whenever you assemble, keep your hand like this and just slide it in. Understood? Then there are dots here. Can you see these dots? 1 dot, 2 dot and 3 dot. So you align them and then lock. Understood? Then this is a scope. So this is a scope. So again we can see the dots here. Can you see the dots? Yeah. So you align them and then there is notch here. So you align the notch and dots like this and then go. Understood this? No difficulty, easy. So you need to understand your instruments properly. Otherwise what happens, if you don't know how to use the instrument, you will damage the instruments in an attempt to some people they like this they will do, and then this tip is damaged. Now you can assemble this. Hello madam. पाठवा ना हो पाठ. Understood? Give it to me now. So this is operative sheath. So I keep it here now. Now you see one more operative sheath here. Now compare the diameter of operative sheath. This is larger, this is smaller. Correct? This is 4 mm standard. This is office. Okay, so that is why it is small. So we have office hysteroscopy. Size, yeah, different, yeah. So now this is 2.9 mm scope. This is very delicate. That's why. See, look at the difference in the diameter now. 4 mm, 2.9 mm. Correct? So this is very delicate. That's why I don't use it for teaching. So the information, whatever I am telling you, I also don't handle it. So they are the people who have mastered handling this kind of delicate instrument. So I let them handle it. So all the information I am sharing with you here is same for both 2.9 and 4 mm. Only difference is size. Understood? So now this is again same I am telling you about 2.9. So outer sheath, inner sheath, inflow, operative channel, scope channel, outer sheath, holes, everything is same. And the assembly is also same. Outflow and inflow are never in one direction, so just hold it like this and go in and block. Okay. Is there any question in operative sheath? So up till now we have seen diagnostic sheath and operative sheath. Now we are moving to resectoscopes. Okay. So now resectoscopes are two types. One is monopolar and other is bipolar. Then in both types, monopolar and bipolar, they come in various sizes. So ranging from 15 FR, 15 French to 26 French. So 15 French is smallest in diameter, 26 French is largest in diameter. So here we don't have 15 French, we don't have 16 French. So the resectoscope are 15, 16, 18, 22, 24 and 26. Out of all these, we have 18 French, we have 22 French and we have 26 French. If you want to do only hysteroscopy and if you have a lot of money, you can purchase all the resectoscopes. But for me, I don't have that much of money, so I have purchased only 3. So I will tell you the logic behind why I purchased only 3. So I have purchased 18. Hi Chota. दूसरा हाँ है ना, तो हाँ अंगा ना हाँ चलो. So this is 18 French. So just compare the diameter. This is 18, 22 and 26. So increasing size. So I did not purchase 16 French because for this 18 French resectoscope also I don't need dilatation. Okay. So the work which is done by 16 French resectoscope can be done by 18 French, no problem. Then I have 22 French for slightly bigger pathologies. If the pathology is big in size, then I use 22 French. And for the largest pathology, suppose I have 3 cm myoma, submucosal myoma, or 3 cm mass inside, then I use this larger one. Because the 18 French will have small loop.
26.
Yeah, 26. So if you see the loop size and now see the loop size. Loop में ऐसा loop कुछ है ऐसा loop बघना. So the size difference. So this loop is smaller, this loop is larger. So depending on pathology, we select the size of resectoscope. Understood? Yeah. Now this 18 French resectoscope, 22 French resectoscope and 26 French resectoscope. Yeah. So the assembly is same in almost everything. Only size difference. Now I will demonstrate you 18 French. Outer sheath. See holes. Can you see the holes? Yeah. And inner inflow and outflow on the outer sheath. Same. Then inner sheath. There is no inflow outflow. This has silicone tip. Can you see this? Black here. Yeah. And then the operative, this is the loop electrode. Loop electrode. See this? And this is working element. So there are 4 parts: outer sheath, inner sheath, loop electrode, electrodes. So it can be loop, it can be ball, it can be Collins type. This is working element. So how do we assemble it? First, we take this loop and then can you see the 2 holes inside? So lower hole is for electrode. Can you see that? So we put it inside. Now once I put it inside, you will see it from here. Can you see that? Is it coming? Yeah. Now there is one more hole below this pipe. There is one here on this white thing. White. Yeah. So I insert it from yeah. So it goes inside here and click. See. This is the click. So you hear the click once it is. Let her sit. Yeah. You understood? Okay. Now we take the scope. So first you have to assemble the electrode, then take the scope. This is very delicate, so this has to be used very carefully. Now see the hole inside. Just pass it slowly. No. This has only one hole for the scope. The 2 holes are here, this side. So this goes slowly here. Slowly, and then it will come out from here. See? Now you have to align the electrode in such a way that the scope passes inside smoothly. Otherwise, what will happen if you forcefully put it? See, the lens of the scope will be damaged by this. Are you getting my point? If this is mal-aligned, then the scope can be damaged, and this scope is very delicate and very costly. So you have to put it very carefully like this. Yeah, this. Now once it goes inside, it's okay. So most of the times the scope gets damaged during insertion. So you have to be very careful. See, all these instruments are very costly. So if you damage one of the instruments, then you will feel very bad. So use it carefully. After that, take the inner sheath, and then can you see this triangle here? And then this sheath is also having triangle. So now, up till now, you must have realized that there are some markers on the both sheath. Here there was dot, on some there was line. So here there is a triangle. So you have to align this triangle. Can you see this triangle? To this triangle here. So it goes like this, and then you have to press this. See? Lock. Okay. Now again, this is outer sheath. Now can you see the triangle here? Can you see the triangle on here? So now you have to align those triangles and then press, lock. See, everything is locked. Yeah, careful. That I will tell you. First see, just see. That I will tell you. Outer sheath, inner sheath. Correct? So, how do you disassemble? Again, you have to press this here. Press, it will come outer. Press, inner. Then the scope, you rotate this here. The scope comes. And just keep it inside. Don't keep it out. Never. This is very delicate, so just it goes inside. And now you can take out the electrode. So for taking out electrode, you press this blue button. Got it?
For the introduction, you put this one and this one.
Yeah, do it now. You practice. Here, practice करना. ये ना मारो क्या बात
Only fix.
You have to push it. See, you have to see. Yeah, this hole. Yeah, push. You will hear the click.
And then not to block it.
Huh?
You have to press this.
No. While inserting, you don't have to press it. Heard the click?
Just the click.
Click. Yeah.
This distance, okay.
Okay. Huh? Okay. So you try to assemble it once again. Heard? Okay? Yeah. If you want, you can do that. Just be gentle. Press. Blue one, blue press. Press blue, yeah. Yeah. Don't worry. Okay? Yes. तुला बघायचे ते ब्लू प्रेस कर त्याला काढ ओके आणि टाक पुन्हा खालच्या होलमध्ये टाक येस पुश त्याला येस हर्ड द क्लिक नाउ आफ्टर दॅट यू हॅव टू इनर शीट triangle align the triangle and put it in so one by one everybody you do it one by one. Don't rotate, just align the triangle to triangle. Why are you rotating that? Where is the triangle?
This is the first one.
Yeah, where is the another one? Here. One triangle. See,
Yeah.
you are searching both the triangle on here. See, if one triangle is here, other one will be on this shape.
Yes.
No. So this is one triangle here.
I'm
So
looking for the click.
understood?
Yeah.
So this is one triangle here. This is another triangle. Huh? So usually remember the triangle is near this. This is green. You see, just in front of green there is triangle. Here also, just in front of green there is triangle. Huh? So now you align these both triangles and just press this. If you click. Got it? Yeah. Do one by one. Do one by one quickly, fast. Press. Yes. Just align. Press. Yes. Give it to her. Got it? Huh? Easy. Yeah, but see, somebody is taking care, but you should know. You should know how they work. Huh? Yeah. Okay?
You're very, very, very intelligent, and that's why she's handling this.
No, yes, correct. But unless you know your instrument, you will not be able to do the surgeries properly. Always remember, you should know all your instruments thoroughly. Even though they are taking care, it's okay. But some minor things which they don't understand, you will understand. Understood? Now this is outer sheath. So it again has the triangle. Can you see the triangle? Now there is a triangle here. So it is easy. Now I think it's okay. It's easy. Yeah. So again this outer sheath has holes to collect the dirty fluid inside. Now you see this is thumb operated. This is thumb operated. Means my thumb is moving. Can you see that? My fingers are constant but my thumb is moving. And when my thumb is moving, you can see the loop coming out. And when my thumb is in the original resting place, the loop is going back. Samajh? Huh? Now, see, this and this is same. Now I will show you the difference. Now this is monopolar. These two are bipolar. This is monopolar resectoscope. Now this company is different. That is why there are some differences in the resectoscope assembly. Okay. So now see, this is outer sheath. Same like this. Holes, inner, outer, inner. So how do you know which is outer, which is inner? No, that is okay. The arrow is okay. But suppose the arrow is not there.
Which is near the camera.
Yeah, which is near you is inflow.
And the outside.
Correct, correct. Okay, so outer there is no difference. Same. Inner. Inner. Okay, inflow is again same. It also has the silicon tip. Here it was black, it is white. Now there is difference in this assembly. Now see, I press this, the loop comes out. But here, what they have done, okay, this is loop here and this. We will compare both the things. Now if you see, if I take out the loop, now this working element and this working element, there is difference? Yes, there is difference because this working element has inbuilt this pipe to protect the scope. So once you insert the scope here, so there is, you don't need to align the scope to put in. Not getting? I'll tell you. You get it? So this is the scope. This is the scope which I am putting inside. Now see, I don't have to align it. It goes inside. Correct? But here, in this case, I have to first put this loop inside. Nah. Understood? But here, yeah. And then you can put this. On the scope. Yes, yes, click is there everywhere. Understood the difference? Second difference is the sheaths are same. second difference is hello. ठीक आहे ना, कर, आरामात कर. तिथे स्कॅन चांगला करणं गरजेचं. ओके, सो नाव if you see how it works. So the electrode is already outside. In this, the electrode is not outside. Yeah. Can you see the difference? This is thumb operated. This is finger option. Fingers are moving. Getting the here the thumb moving. Yeah. So for this, when you introduce, you have to keep it closed and then introduce. Here, this is okay to introduce like this, simple. So this is good. I don't prefer. So whenever you purchase a resectoscope, you should purchase a thumb operated resectoscope, not finger operated. Are you getting my point? See, this I purchased this when I was new, when I was not knowing anything about hysteroscopy, and then I purchased this. And this is 26 French monopolar. I was not aware of all these things that time, so I purchased this. But now, if you are purchasing a resectoscope, tell them that you want finger operated, not finger operated, thumb operated, not finger operated. What? I'll show you. That is electrode. Just now we are comparing the resectoscope sheaths. I'll tell you. Understood this? Difference you understood? This is bipolar, this is monopolar. Distension media required for this is normal saline, glycine. Difference you understood? Size 18 French, 26 French for larger people. Got it? So I prefer this because for diagnostic purposes we are using normal saline, and then after using normal saline, if you need to use resectoscope, if you use bipolar, the same distension media can be used for operative. But if you are using monopolar, you need to change the distension media, let the normal saline wash out, and then you should use the monopolar. What happens if you use normal saline and monopolar? There will be ions, electricity will spread. Electricity will spread in nearby organs, bowels, everywhere. So we cannot use normal saline with monopolar. We have to use glycine, hypertonic saline, hypertonic. Okay? Understood? Now you were asking about, this is roller ball. See, this is Collins knife, Collins, CO, Collins knife, yeah? Then this is loop. So there are different varieties of electrodes depending on what pathology you are dealing with. Now if you want to ablate the endometrium, you can use this roller ball for my ablation. If you want to resect the polyp, you need to use loop. If you want to resect the septum, you need to use Collins knife. Understood? So depending on pathology, you will change the loop. Right? Okay, now is there any doubt in all this assembly? Clear? It is very easy. What? That is mechanical morcellator you are asking. Yeah, that is different. Yeah, that is different. Yeah. So, do you understand this?
Yeah.
Is there any doubt? No. Do you understand about distension media? What to use when? Yes. Now, when you use normal saline for a pathology. You have to, when you are resecting some pathology, you have to calculate the amount of fluid used and amount of fluid coming out to find out the deficit. So for normal saline, the allowed deficit is 2500 ml. Understood? So once the deficit reaches 2000 ml, you should stop. Don't go till 2500. But for glycine, the deficit is 1500 ml, less than normal saline. But what I do, if it reaches 1 liter to 1.2 liter, I will stop. I will not go to the uppermost point and wait for the complications to come. Yeah, correct. So it is not the amount of fluid used, it is about amount of fluid absorbed. So it is fluid deficit. Not even if you use 15 liters of fluid and 14 liters have come out, no problem. But if you have used 5 liters of fluid and only 1 liter of fluid has come out, that means 4 liters of fluid is inside the patient's body. So that is the problem. How do you calculate? So you have to put a plastic sheet below patient and you have to measure the amount of fluid coming out. So what you do, you keep a bucket. When you start the hysteroscopy, give patient a bit head high, so that the fluid doesn't go below patient's body. If you give head high, the fluid will come down. If you give head low, the fluid will go back. Okay, so what I do is I give patient a slight head high, then we put a plastic sheet, disposable plastic sheet, and we collect all the fluid into the bucket. And one of the assistant, so we have 2 buckets, one of the assistant is constantly changing the bucket in between the procedure to calculate the amount of fluid coming out. So if the bucket is having markings, it's okay. If it is having markings, it's okay. If it doesn't have marking, you can have something to measure with marking, and you should see, once you are quite senior, you can judge. Now I judge, for smaller pathologies I judge, but for larger pathologies, if I am using a lot of fluid, then I have to calculate, because judgment can be wrong sometimes. For smaller pathologies, suppose see, for example, you are going to use 1 centimeter polyp. You are going to remove 1 centimeter polyp and you are using only 2 liters of normal saline. Do you need to find out the deficit? Because the amount of fluid used itself is less than 2 liters. So why do you need to calculate? Understood? So, but when you are dealing with larger pathology, the amount of fluid used is more than 8 liters, 10 liters. That time you need to calculate the deficit. You got my point? And most of the times, the larger pathologies are very less. Like most of the times we are doing diagnostic studies and smaller polyps and septum resection, all these things. And they itself require less than 1 liter to 1.5 liter fluid. So you don't need to calculate. You really don't need to calculate. Got my point? Yes. Now about the pressure of the fluid. So we use hysteromat to calculate the pressure inside the uterine cavity. So for all the cases, diagnostic as well as operative cases, we keep pressure around 80 millimeter of mercury. It should be more than 45 to inflate the uterine cavity, less than 95 so that the fluid is less absorbed, mean less than mean arterial pressure. Understood? But sometimes what happens, even if you keep it at 80, but the uterine cavity doesn't inflate, then you ask your assistant to increase the pressure. So that is allowed. Why? Because even though the machine is showing 80, but inside pressure is not 80 because of fluid leakage. If the cavity is not distended, that means inside pressure is less than 15, even if machine is showing 100. So you can ask him to increase the pressure till you see cavity distension. Once the cavity is distended, you ask him to stop. And when you are using high pressure, you try to finish the surgery quickly so that there is less fluid absorption. Alternative to this, what you can do, if the fluid is leaking, then you can apply the clamps to the cervix. And if you apply the clamps to the cervix, again uterus will start distending. You got this? Easy? No? Quite easy, right? Do you have any doubt about the distension medium? So what happens if the fluid is absorbed? Yeah, so the absorbed fluid will cause fluid overload, right? So if it goes to lungs, pulmonary edema; if it goes to the heart, cardiac; if it goes to the brain, so everywhere, right? So it is very dangerous, and sometimes patient may end up in ICU because of fluid overload. So we will discuss about complications of hysteroscopy also. So when you are doing hysteroscopy, if your assistant doesn't check the air column, the tubings used for hysteroscopy has some air inside, and you are doing the operative hysteroscopy, then there can be sometimes there are incidences where embolism have happened and the patient has to lose her lung. So you should be careful there is no air bubble inside. Okay, so before starting the procedure, check all the tubings, there is no air bubble. Okay, then there can be perforation. Okay, so if there are synechiae in the endocervical canal, if there is Escherman syndrome, postmenopausal, small uterus, so there can be perforation. So you have to be very careful. Then there can be excessive bleeding when you are resecting a larger myomas, okay, a larger septum, so there can be excessive bleeding. Okay, so all these are complications. So you have to be careful of these complications. You have to predict the complications. Suppose you are having larger myoma, you have to predict that if I use more fluid, there can be fluid overload. If there is a larger vessel, there can be blood loss, there can be perforation, and you have to accordingly act. Yes. So the most important thing before doing hysteroscopic myoma resection is to find out the grade of the myoma, whether it is 0, 1, 2. Yeah. So if it is 0, you can do it in one setting. I don't think there is a problem. If it is 1, then also there are chances that you finishing the case in one setting. But if it is grade 2, more than 50% inside the myometry, then there are chances that you need to do it in 2 settings. Understood? So what I do, if myoma is larger in size and it is grade 2, suppose it is a 4 cm myoma, grade 2, that day you saw, what I did? Laparoscopy. I go through laparoscopy, I cut everything and then I take out. Rather than doing it in 2 settings, I do it in 1 setting laparoscopy. Because patients here don't accept 2 settings. And again, doing larger myomas by hysteroscopy is very complex surgery. There are more chances of complications. So I do it laparoscopy. It is not less than 3 centimeters. You competent. If you are competent enough, you can remove whatever. It was inside the cavity. The first day what we did, it was a pedunculated submucous fibroid, but the size was 7 centimeters. Yeah, so that is why I did it laparoscopy. Yeah. That is why I prefer. See, there is no clear-cut guidelines which fibroid is to be done which way. There are many surgeons who do it laparoscopically, there are many who do it hysteroscopically, there are many who do it vaginally. What they do, you know, they open the posterior fornix, they take out the uterus, they take an incision, they do myomectomy, they suture it and then again repose it. So, see, it depends on your competence, what kind of surgeon you are. Understood? So you should know all the methods of myomectomy. You should know all the methods, and then according to your competence, you can do the myomectomy. Nothing is right, nothing is wrong. Only thing is your patient should be safe, not happy. Safe.
So
Yeah. If she is safe, then only. Yeah. So what I feel, if the myoma is too large, and if you resect a lot of endometrium, then see, anyways you are going to do myomectomy in patient of infertility. Huh? No, not bowel. Bowel is okay, but first, yeah, if you are bowel injury is after perforation, but if you are submucous,
Hysteroscope. And this hip will I live in books and in literature. This damage to endometrium then open and
how?
Scarring.
How?
Scarring on the endometrium. And if
We don't, anyways, if you do laparoscopic myomectomy, we don't suture endometrium. We suture only myometrium. So how the scarring is going to happen? Yeah, it is all theoretical. See, again I am telling you, in all these high-end complicated cases, the guidelines are different with everyone. The hysteroscopic people will say it is better hysteroscopically, the laparoscopic people will say it is better laparoscopically. You have to decide what is best for your patient depending on your clinical judgment and your experience and your all those things. Got it? Now I think everything is clear about this. Less. Yes. So if you
push out the
yes. So if you feel that the more fluid is absorbed, your anesthetist will manage. See, he knows how to manage fluid overload, so he will manage. But you should also know it is not that correct. So is this clear now? Huh? Bara is doubtful. Okay. So anyways, we are recording this thing. So if you forget something, you can again go through it. Yeah. So now I will tell you how to assemble everything. Yeah. Okay. Come here. Shubham. Now see. This assembly I have already explained you how to assemble the resectoscope. The scope is inside. The light cable will go from below, and the camera we are going to attach it here. Okay. And the normal saline will come from above up. So to remember, the rain above, sunrise from below. Okay. And the outflow cable, if you want to attach, you can attach here, and you can put it into the whatever you have, the collecting, right? Then you have to go inside like this. This is the endo. Can you see the endocervical canal? Yeah. Can you see the endocervical crypt as well? Yes or no? Yes. Can you see the notch also? Yeah. So the rule in hysteroscopy is you cannot push it like this. See, if I push it like this, here it will go because this is a soft silicone, but in patient it will not go. So here the rule is that notch you need to align to the opening. Can you see that opening?
Yes.
Yeah. So what I will do now, if I want to align this notch, I will dip my hand down. See, and then I align this. And now I will go smoothly. You got my point? Now I am into the endo. You want me to repeat? Huh? Yeah. See. This is not properly. Yeah. This is again I will explain you. So if I am at the external os now, I can see the endocervical canal. Now can you see that notch, Dr. Bara? Yeah. So if you push it like this, it will not go inside. If you want to go inside, you need to align the black notch to the opening. Understood now? And now you can go in. This is the basic. Now once you are into the cavity, now see the panoramical. See, is this panoramic view of the cavity? Tell me. Yes or no? No. Because in panoramic view, you see whole cavity. Here, the maximum part covered is anterior wall, right? So now I take my hand up, so you will see the panoramic view. Can you see the panoramic view now? So this is called as panoramic view, where you see anterior, posterior, lateral and orifices. So this is how you align it, and then you go slowly inside here, slowly inside here. Now you have reached till fundus. Now once you reach the fundus, if you want to see the right side of the ostia, see, patient's right is on this side. Understood? You need to rotate the cable to your right. Can you see the ostia? Yes? Okay? Okay? Then, if you want to see the left side ostia, see, now I am changing my hand. I am holding the camera with right hand, and then see. Can you see the left ostia? Yes. Easy? Then if I want to see the anterior wall, suppose there is pathology on the anterior wall, I need to keep the cable at 6 o'clock, and then I move the whole assembly, right? If I want to see the right lateral wall, patient's right lateral wall, I will take the cable to the right side, and then I will see the right. If I want to see the left wall, then I will change the hand, and see the left lateral wall. And if I want to see the posterior wall, the cable will come to 12 o'clock, and then I see like this. Correct? Is there any doubt in this? No? Again, you come out. When you come out, after going in, you see all these things. Then when coming out, don't come out like this. No. When you are coming out, again, you have to be panoramic. And then come out. See this? See this panorama? So that you see, is there any bleeding, is there anything coming out? So you examine the whole cavity and then come out. This is what? Internal walls. When you come out, endocervical canal, endocervical canal, and then the external walls. Is there any doubt in this? No? Now one by one you come. Very much clear. I hope I taught you something new, because already you are already doing it.
Yes, but sometimes you are detailed steps.
Yeah. So
Yes.
now understood in detail. Good. Huh? In organized manner, stepwise manner. Now there are less chances of doing mistakes, right? Yeah. But in hurry, yeah, do it fast.
My patient wants today.
Okay. Huh? Lot of gynae. So they want.
Minimum 10 gynecologists, each have 2-3 operations and all they want.
Yeah, but now still, once you understand this, you can do things much faster.
Yes.
Once you understand. Young minds learn very fast.
Yes.
Very good. She is doing it very fast without telling her anything. She is just doing it. Coffee? Is this coffee? गरम करतो. हाँ ये ना. Yes. हाँ panoramic है. समझ लेना. Cannulation का. He's making it hot.
No,
It was cold coffee. It was cold coffee.
we do and it was
Yeah, so I like it hot only. Okay, no problem. No problem.
Yeah.
Yeah. I take it.
With DNB.
I take it without sugar only. So the coffee powder you brought from Mira? The coffee powder from here? Previously one Saudi Arabia madam, she brought it from her home country because she didn't like the coffee here. I don't know what. ठीक है ना. See what you do. आता काय प्रॉब्लेम आहे ना. You are on the which side you want to do?
Right.
Right ना. Right side ना. Right side तो अच्छी है. इथे आहे. Understood. इथे है ना. आणि याचा टर्न आहे ना असं नाही वगैरे. समजलं तुला? हे गोल फिरवायचं असं. हे केबल अशी समजलं तुला. आता हे असं केलं की हे जाईल जवळ आणि याच्यात कसं आहे ना कर्वेचर चांगला नाही आहे. जस्ट ट्राय टू टच देअर. इट्स ओके. बघ द मिस्टेक यू आर मेकिंग इज दिस. यू शुड नॉट रोटेट इट. कीप इट लाईक. सो द टॉप शुड बी फेसिंग अप आणि हे फक्त कॅमेरा विल मूव इन धिस डायरेक्शन. हां लाईट केबल मूव राऊंड. ओके. No problem, no problem. With practice, you will gain the confidence, you will gain the accuracy, and the time will reduce. The first time she was doing, she took a lot of time, but second time she was just in seconds. So, yeah. You have no shaver. I also don't have shaver. Yeah. So what I do, yeah. So what I do is when I do polypectomy, I don't cut at the base. Yeah. So I keep, if I am using resectoscope, I will slice it. I will keep on slicing it. By grasper also, if I am using scissors, not grasper, scissor. So if the polyp is like, suppose this is the polyp. So I will cut, make 4 pieces and then, yeah. No. Yeah. So I have a video for that also. Yeah, we have the video. Make 3-4 pieces before you cut the base. Otherwise, if you cut at the base, it will keep on rotating.